Right, good morning. Can you hear me in the back? Right. So I wish I could talk ad-lib just like Dr. Kleiman did about this whole talk. So I'm going to actually take the help of slides, like I said. So always look up. So I'm going to look up every slide and tell you about ST segment elevation and myocardial infarction in 15 minutes. So as a fellow, if I remember, the hardest thing for me was if somebody handed me the EKG and asked me to make the decision to activate the cath lab. Because the first thing that came to my mind is, am I going to miss it or am I going to overcall it? Okay. So I can tell you one thing, this one fear you cannot get over throughout the rest of your career. I mean, there's always going to be circumstances where you're going to need help. And so I will, one thing that you want to focus on when you're looking at an EKG is just don't focus on the EKG alone. So ST segment elevation, just the diagnosis of any condition, especially in an acute situation, depends on taking a focused history from the patient. So if you look at the patient's symptoms, and if they are suggestive of acute coronary syndrome, in the presence of the EKG abnormality will give you the most appropriate diagnosis of calling it or not calling it as segment elevation. And then you don't want to wait for the labs because labs usually will present much later and you don't want to lose that initial very important time. For ST segment elevation, there are strict criteria per guidelines. If you look at the 12-lead EKG alone, there's 1.5 to 2 millimeter ST segment elevation in V2 and V3, and 1 millimeter ST segment elevation in rest of the 12 leads in at least 2 contiguous leads. It is recommended that if you have an inferior wall myocardial infarction, inferior wall changes, consider using right-sided leads V3R and V4R, and the threshold value for ST segment elevation in V3 and V4R is 0.5 millimeter. If you do suspect a circumflex territory infarction, sometimes it could be silent on an EKG. So consider doing V7, 8, 9, which is extending the V6 to the mid-axillary line, posterior axillary line, and behind it is a scapula to increase your sensitivity of picking the ST segment changes. So with this, I will give you a few examples. This is a 59-year-old patient who has history of liver transplant, came to the hospital with chest and abdominal pain. Like anybody with chest pain or abdominal pain or any pain nearby, they get an EKG and a troponin. So her initial troponin was 0.6, and an initial EKG is on the August 24th. You can see is fairly unremarkable. So she was called as it's most likely a non-STL segment elevation MI, started on heparin. In the meantime, she got an echocardiogram that showed pericardial effusion. So they stopped the heparin, and over the next day, over the next 24 hours, you can see her EKG has some dramatic ST segment elevations. So this patient was later on diagnosed with pericarditis and ITP. This is a patient, 54-year-old, presenting with nausea, vomiting, comes to the emergency room. This is the EKG prior, and this is the EKG at presentation, the bigger one on the right. So here you can see there's some dramatic ST segment elevation anterior wall. ER physician sees these changes, and what do? Computer is also calling it, so they call it an ST segment elevation myocardial infarction. It seems appropriate, situation. Patients having nausea, vomiting, even the diabetes could be a symptom of infarction, but obviously no chest pain. So we took him to the cath lab, and coronary anatomy is normal. In the meantime, somebody in the monitor room said, "Hey, Dr. Gilani, by the way, his potassium is 8.8." So there you go. So those were peak ST segment, peak T waves, and those changes in the V1 through V3 are not related to ST segment elevation MI. So in clinical practice, sometimes it's really, really hard to make the distinction. This is a patient who's been having chest pain for 3 days. That initially it started 3 days ago. It's continuing to have chest discomfort. It never go away. His initial troponin was positive, so we call it non-ST segment elevation MI, but you really don't have any EKG changes. His EKG at presentation was completely normal. This is his EKG. I guess posterior leads or left lateral leads might have been helpful in this situation, but they were not done. He went for coronary angiogram, and he had a mid-circumflex 100% occlusion, thrombotic occlusion. It was treated with the PCI. So circumflex territory infarctions can be silent, and in these situations, if you suspect that, doing left lateral leads, repeating EKGs, or doing a bedside echocardiogram will help you make the diagnosis. This is a 37-year-old patient with chest pain, shortness of breath, diaphoresis starting 30 minutes ago. So symptoms of ischemia with clear-cut ST segment elevations in the inferior wall, correct? So this patient had mid-RCA occlusion, consistent with the ST segment changes in the inferior wall. This is a patient with who has had PCI of the RCA in the past, was off aspirin for some procedure, comes in with severe chest pain, shortness of breath. So clinical situation consistent with acute coronary syndrome, and EKG showing inferior ST segment elevations. So, and there's some lateral ST segment elevation also. So this goes with the inferior wall infarction, inferior lateral. He's got a big posterolateral branch. This patient was very sick. Sometimes these patients, I guess right-sided lead might have been helpful in this case also. Just look for RV infarction. He's got a proximal to mid huge RCA occlusion. Was very symptomatic. This patient with the left shoulder pain started yesterday, lasted 1 hour, it resolved, and he came back today, so he rushed to the emergency room. You can see he's got QS complexes in the anterior leads and ST segment elevations, more than 2 millimeters, consistent with the anterior wall infarction. So he had proximal LAD occlusion. On the right side, you can see there's a stump in the LAD that was treated with an angioplasty and stenting. And this is another female who came in with sudden onset of a severe shortness of breath. EMS was called. She was intubated in the field. So this is her EKG for comparison is completely normal, and you have tombstoning ST segment elevation in the anterolateral wall consistent with an LAD territory infarction. So this patient, previous LAD territory infarction, not as symptomatic. This one comes in with flash pulmonary edema. Much more symptomatic, that was treated with a PCI, primary PCI. It's a 47-year-old female with chest pain, nausea, sweating. EKG for comparison completely normal in the past, and here you can basically see computer did not call it as ST segment elevation MI. Maybe if you look at it, there is 1.5 to 2 millimeters ST segment elevation in V2, not in V3, not in V1, but there's peaked T waves. So looking at this EKG, took this patient to the cath lab. He had proximal LAD occlusion. So again, 3 LAD territory infarctions with not 3 different looking EKGs, but one not very clear. So in this patient, sometimes in acute coronary artery occlusion, acute STEMI, you can have peaked T waves before the ST segments become more pronounced. So this might be the case in that. This is a 57-year-old patient with chest pain, with no prior history of CAD. And here you can only see ST segment elevation in the lateral lead, V5 and V6. The rest of the EKG has no significant ST elevations. So had very distal circumflex occlusion. And this is the area that I showed you in the circumflex. Sometimes even be silent on the EKG. So, but here, the aspiration thrombectomy followed by PCI and stenting was performed. This is a patient from a nursing home who was intubated. EMS was called because the patient was shortness of breath. They arrived on field, intubated the patient, brought her to the emergency room. Her EKG shows similar to what the other LAD territory infarction will show you, anterior wall ST segment elevation. So it goes to the cath lab. Can you play this, please? Not automatically right. Thank you. Okay, that's all right. It showed symptom consistent is this patient's whole apical ballooning syndrome. You know, the patient with Takotsuba's cardiomyopathy, they have basal hyperkinesia and apical ballooning. This patient had apical ballooning changes on the EKG, on the echocardiogram and the LVgram. So this patient's EF recovered in 1 to 2 weeks after discharge. She was treated medically. This is the patient who was transferred from an outside hospital where he presented initially with abdominal pain, chest pain. He was diagnosed with uropathy, acute renal failure with creatinine of 14, and acute MI with anterior wall ST elevations. He was taken to the cath lab at outside hospital where they performed PTCA, and they did not place a stent because of severe 3-vessel CAD, and they wanted him to and he was very sick at that time. So he had persistent ST segment elevation. He was finally transferred to our hospital for evaluation for CT surgery for possible cabbage. This is the EKG on presentation, and he is relatively stable. He's hemodynamically stable, having maybe minor chest pain on the right side, but this has been going on for several days. It's nothing new. So we decided we did a bedside echo on him. He had anterior wall apical akinesis. We decided that we're going to take care of him in the morning with consult with our CT surgery colleagues. 4 hours after presentation, the guy who goes into electromechanical dissociation, PEA, and dies. We performed an autopsy. He had LV, anterior wall rupture, free wall rupture. So you can have residual ST segment elevation in patients after an acute MI, and that could be the sign of developing aneurysmal changes in the LV. I'm not sure anything could have been done to prevent that. So this patient, a 69-year-old who came to the emergency, was brought to the emergency room by EMS. Patient collapsed in the field and was intubated, and there was possible some tachyarrhythmia in the field, but it was not available. EKG leads were not available. This is the EKG on the right on arrival, say the acute MI. Maybe there's some ST segment elevation in the lateral leads, one in AVL. So very important, if you have not a very clear history, to be careful about taking these patients with out of hospital collapse or atypical symptoms to the cath lab. So this patient was asked to go through the CT scanner before coming to the cath lab, and CT scan, the brain showed a subarachnoid hemorrhage. Another patient, 46-year-old, who was visiting Galveston, was apparently running, leaned against a pole, and then passed and had a seizure-like activity. EMS was called, was brought to the ER. He was sedated, arousable, but unable to provide good history. So anterior ST segment elevations, lateral T-wave inversions, may be consistent with ST segment elevation MI, but again, the history is not very clear. So in this patient, we're not very sure. It takes about 5 minutes to get a CT scan of the brain, and again, another case of a subarachnoid hemorrhage. So I showed you that ST segment elevations could be because of myocardial ischemia, post-myocardial infarction, residual ST segment elevations, pericarditis. It could be a normal early repole pattern. It could be because of bundle branch block, left bundle branch block, or LVH, hyperkalemia, hypothermia, myocardial injury, or myocarditis, Brugada syndrome. Intracranial hemorrhage can present with changes like this. ST segment elevation happens, usually constitutes approximately 30% of acute coronary syndromes. There's about 750,000 cases of ACS in the US. Male-female ratio is 3 to 2. Overall incidence of STEMI in the population is gradually declining, and overall MI is also declining. STEMI remains a morbid condition. The in-hospital outcome from this action registry, mortality is about 6.4. and heart failure 4.4, and incidence of shock is 4.4%. In this registry, among all the PCIs performed in the US in 2014 data, approximately 20% were performed for emergency cases, including the STEMI. In STEMI, the goal is to really reduce the ischemic time, and ischemic time doesn't start from the time of arrival to the emergency room. Ischemic time really starts from the patient's onset of symptoms. So it's very important for these patients to be presenting to the emergency room on time, because you can reduce the time from there on forward to taking care of them. But the most important time is for patients' education. So patients who are at risk of having acute MI, they should be educated about how to early activate this EMS system. Still, approximately 40% of the patients who come to the emergency room, they walk into or are driven by a friend or themselves to the emergency room. They don't use EMS. There are benefits of using EMS because of the capability of the EMS to provide initial care, take vitals, and make the diagnosis, transmit the EKG to the ER, and preferentially transport the patient to the PCI-capable hospital, which is the preferred mode of revascularization. So pre-hospital initial assessment includes focus history, vital signs, EKG. It helps you, the EMS, to transmit the EKG, make the diagnosis, and transfer the patients to the PCI-capable hospital. You can even activate the STEMI team before the patient arrives to the hospital, helping reduce the ischemic time. So you're going to do a brief and targeted history in these patients. The important components are, you want to find out if they have any, what are the onset of time, what time the symptoms started, what are the risks associated with STEMI if they are in heart failure or shock, being the highest risk patients, the risk of reperfusion therapy, contraindications of fibrinolytic therapy, contraindications to anticoagulation, exercise issues, briefly identifying patients for perfusion therapy, and how much time will be required for you to perform PCI versus fibrinolytic therapy at the institution where the patient arrives. So preferred therapy for these patients per guidelines, if the patient arrives to a PCI-capable hospital, is to take the patients for primary PCI with first medical contact to balloon time or to device time of less than 90 minutes. And PCI being the preferred therapy after the diagnostic angiogram with CABG and medical treatment in small group of patients. If the patient arrives at a hospital that is not PCI capable, then even then the preferred therapy should be that if the patient could have primary PCI performed from first medical contact to the primary PCI with the total time of being less than 120 minutes, is preferred to transfer the patient. And the goal should be that from the arrival of the ER in the ER to the transfer out of the ER to the following next hospital should be less than 30 minutes. So this initial evaluation has to be very quick diagnosis and already having a mechanism to transport these patients to a nearby hospital. If you cannot do that, achieve the goal of 120 minutes, then the recommendation is to give these patients fibrinolytic therapy within 30 minutes of arrival to the emergency room. And as you know, the longer the door to balloon time, the higher the mortality significantly increases, and there are benefits of primary PCI over fibrinolytic therapy, has been well documented in mortality and recurrent ischemia and myocardial infarction. If the patient arrives to a non-PCI capable hospital, the invasive strategy should be considered if the skilled PCI lab is available with PCI within 120 minutes from first medical contact. High-risk patients should be considered for primary PCI. Those include cardiogenic shock and patients in heart failure. If you have contraindications for fibrinolytic therapy, these patients should be transported to a nearby hospital where primary PCI can be performed. If the symptom onset was more than 3 hours, these patients' lytic therapy is most effective in the first few hours of symptom onset. And if the diagnosis is STEMI in doubt, you don't want to give these patients lytics because of lytic-associated complications. You may prefer these patients to be transferred. Whereas fibrinolysis is more recommended if there is early presentation and if invasive therapy strategy is not available, or if there's a delay in transport. So this slide just gives you the guidelines recommended treatment goals. First medical contact to device time of less than 90 minutes or less than 120 minutes if the patient is arriving at a non-PCI capable hospital. And reperfusion therapy should be considered in patients who have symptom onset between 12 to 24 hours. It's a class 2A recommendation. And in cardiogenic shock patients should all be considered for transfer to a PCI capable hospital for revascularization is class 1 recommendation. And the benefit of PCI over fibrinolytic therapy is dependent on symptom onset, duration of symptoms, patient's age, and location of myocardial infarction. Particularly more important with age and symptom onset. If you have an early symptom onset, then the time door to balloon minus door to device time is much shorter compared to if the symptom onset is much longer, suggesting that lytic therapy should be administered early if you have a patient who comes in with very early onset of symptoms. So if patient has ST segment depression, obviously you do not want to give these patients lytic. There's a class 3 recommendation for that. So what kind of antiplatelet anticoagulants should you use in patients who go for primary PCI? Your options include loading dose of aspirin, ticagrelor. Aspirin, everybody should receive aspirin, loading dose followed by a maintenance dose. Among the P2Y12 inhibitors, patients, you have an option for class 1 recommendation for clopidogrel 600 milligram dose, prasugrel. Particularly remembering for prasugrel, there's a harm in patients with prior history of stroke or TIA, and ticagrelor 180 milligrams as early. All three, either one of these three should be administered as soon as possible. And for ticagrelor, the contraindication will be severe liver disease and history of intracranial hemorrhage. Among the 2B3 inhibitors, the class 2A recommendation, you have 3 choices. And you can also use intracoronary efiximab, the class 2B. There's some data of benefit. So those are antiplatelet agents. You pick aspirin and one of the P2Y12 inhibitors. Among the anticoagulation, your choices are unfractionated heparin or bivalirudin, and bivalirudin monotherapy is preferred if you're planning to use unfractionated heparin or plus glycoprotein 2B3 inhibitor. Aspiration thrombectomy, the most recent recommendation is that there's no benefit. This class 3 recommendation, routine aspiration thrombectomy, but it could be considered as a selective and bailout strategy as class 2B recommendation based on most 3 recent trials in FUSE, MI, TASTE, and TOTAL. So culprit only versus multivessel PCI, there's a lot of recent studies published. So the most recent 2015 guidelines updates suggested that it could be considered at the time of, in patients who are hemodynamically stable at the time of the primary PCI or as a planned strategy. Radial versus femoral access for STEMI, there's a clear benefit in this meta-analysis of in terms of mortality, MACE, and major bleeding for patients with STEMI who have for radial access. And your choices among fibrinolytic therapies are 3. With fibrinolysis, you want to use antiplatelets, aspirin, Plavix, and heparin. And then after fibrinolysis, you should transfer this patient to a nearby hospital for early angiography. So in patients who have STEMI and out-of-hospital cardiac arrest, consider it's a class 1 recommendation to provide them hypothermia therapy for the first 24 hours. So consider that also. So in short, in interest of time, I will stop here. Thank you very much. Please, it's a lengthy topic. I apologize for running over. So this is my final slide. You can read it. Thank you.